Good morning. Happy Monday. My name is Jessica Holmes. I'm one of the board members, and Chair Foster unfortunately was unable to attend this morning, so I'll be chairing this meeting in his absence. Dave will be on in just a quick second, so I think in the meantime, I will call the meeting to order with the first order of business being the Executive Director's Report. Director Brown, do you have any updates that you want to share with the board and with the public this morning?
Good morning.
Good
Thank
morning.
you. I don't have any updates for today.
Okay, thank you. All right. Well, then we will quickly move right on to the second order of business today. It's a presentation by Hillary Watson, our Senior Health Policy Analyst with the board, on a proposed draft policy related to notification of hospital service reductions. So, Ms. Watson, the screen is all yours if you want to share it and walk us through this policy change.
Wonderful. Thank you, Member Holmes. Let me just pull up our slides here. Right. It's getting organized. Are the slides up on the screen for everyone? Can you see those okay?
Yes, perfect. Thank you.
Okay, wonderful. So, well, I'll be leading us through the presentation today. I just wanted to first acknowledge a couple folks on the team that have been working on developing this policy with me. Elena Barabee, the Director of Health Systems Policy, Mark Hengsler, our staff attorney, and Matt Sutter, the Director of Health Systems Finance. They've had great leadership and collaboration in this work, so just want to take a minute to thank them. So we are glad to be here with the board again for our second conversation about the notice of service reduction interim policy that we are working on. Moving to the next slide here. Just a quick note on the agenda, a reminder that we were before the board on August 27th, introducing this work stream and reviewing the guiding legislation. And today our plan is to review the actual draft policy document, step through it together, and then open it up for discussion. So I recognize that this is the first time many on the call are seeing the policy, which is hopefully now posted to our website under today's presentation. So just want to remind everyone that this is not the only opportunity to provide feedback. I really encourage everyone to take a look at the policy draft, and we certainly welcome written comments after this presentation. And our plan, which we also reviewed on the 27th, is for the public comment period to stay open through the week. And then depending on feedback and whether or not we hear that people need more time, we may extend that public comment window out a ways. So as I mentioned in my presentation before, we have a hope and a goal to present a more final version of the policy to the board for possible vote next week, but we will stay tuned and see how this week goes and what kind of feedback we get. Okay. So this slide is the same slide that we reviewed together on the 27th, just a refresh and grounding for folks. The statute requires hospitals proposing to reduce or eliminate any service in order to comply with a budget, to provide a notice of intent to the Green Mountain Care Board, the Office of the Healthcare Advocate, the Agency of Human Services, and members of the General Assembly, not less than 45 days prior to the reduction or elimination. So that notice needs to explain the rationale for the reduction or elimination and describe how it is consistent with the statewide healthcare delivery strategic plan once established and the hospital's most recent community health needs assessment. The board may evaluate the proposed reduction or elimination for consistency with the statewide healthcare delivery strategic plan once established and the community health needs assessment, and may modify the hospital's budget or take such additional actions as the board deems appropriate to preserve access to necessary services. So a service that has been identified for reduction or elimination in connection with the transformation efforts undertaken by the board and the Agency of Human Services pursuant to Act 167 does not need to comply. And again, if folks want to review the Act 68 language, there is the link at the bottom of the slide there for a deeper dive. Okay, so continuing the messaging in our last presentation, this first draft of the policy is intended to be an interim policy. Given that the statewide strategic plan, which really is a key input to the evaluation of the service reductions and eliminations, may not be complete until January of 2028, so that's a ways out. And given that this section of the legislation became effective back in June, this past summer, we're working to get this policy and process in place so that folks are, aware of the expectations and how the board plans to move through its review of these notices, especially, absent the statewide strategic plan. Apologize for my voice and sniffles. My children have shared their start of the school year germs with me, so I'm a little under the weather this morning, but so this policy will likely need to evolve over time, but getting an interim policy out there will allow us to learn more about how service decisions are made, when such decisions, warrant a deeper discussion with the state, and how this work intersects with the board's hospital budget review process and our other regulatory work, thinking about reference-based pricing, federal reform models, global budgets. There's a lot of connection points here. So given that the healthcare landscape is changing rapidly, we know this policy will likely need to flex and adapt over time to stay current. So now we'll actually walk through the document and give everyone an idea, of what we have outlined at this point in time. So we start with purpose and statutory authority. And just a note, in case it's helpful for folks, my slides just show kind of the key points and highlights from each section of the policy draft document, follows the same flow. So if it's helpful, folks are welcome to have the draft policy document up as I talk through it. I just didn't want to lift all that language because it would have made the slides very, very busy. So the first section here really just points people to the legislation that gives the board this authority and outlines the necessary components of the process. So this legislation really provides an opportunity for greater awareness and the opportunity for state intervention. And, we recognized in our presentation the week before last that historically it has been 100% hospital choice which services to provide where, and the decision driving those changes are not always transparent. So this new statutory language, as well as the authority given to AHS to lead health system transformation, really gives the state a larger role in working with the delivery system to ensure that we're prioritizing the services that Vermonters need and not cutting services when there are other ways of addressing the affordability crisis. So the overview here is really just designed to set the scope, much of which is established in the legislation. We don't want to spend too much time here since we'll dive into each of these sections, but it is here for everyone to reference as just a high-level snapshot. All right, so here we are at definitions. And as you could imagine, this is one area where we really spent a lot of time and welcome feedback. We define service, reduction, or elimination. what is exempt from the policy, what it means for the reduction or elimination to be in order to comply with a budget, and also the statewide healthcare delivery strategic plan, as well as the community health needs assessment. So I'll go through each one of these individually. And again, there's more language in the draft document for folks to review, but I will read some of it out loud just to make sure we're all on the same page here. So for the purposes of this policy, service is defined as diagnostic, treatment, education, or any other clinical activities offered by the hospital or its subsidiaries or affiliates. A service may be designated by the hospital as a service, practice, department, unit, specialty, or subspecialty. Reduction or elimination is defined as intentional actions and/or decisions with the potential to decrease patient access to the service. So in addition to outright elimination of a service, such actions could include discontinuing the service at a specific location while continuing to offer it elsewhere. So this includes relocating a service to a different address, reducing the clinical capacity of a service in terms of operating hours or clinic sessions by 50% or more, selling, transferring the ownership of a service or facility, including hiring a vendor to provide the service, selling or decommissioning of major equipment, such as CTs, MRIs, any reduction in inpatient beds or staffing of those beds, and any reduction in emergency or urgent care capacity. So service line reductions and/or eliminations exempt from the policy. At this time, the draft policy points people to the Agency of Human Services Healthcare Transformation webpage, where we anticipate a resource being developed that lists services exempt from the policy. And that resource has not been built yet, and there is a footnote that states that no services have been identified for exemption at the time this policy is adopted. So this is an area where we have received a few questions, so I just want to spend a little time explaining our thinking here. One natural place folks go when reading this section of the legislation is the community engagement to support hospital transformation final report released by Oliver Wyman last year. So that report was very much sort of a first phase of the current transformation effort. It was a reflection of hospital finances, provided an analysis of future financial need, pointed out critical areas where structural changes are necessary, and provided hospitals and the state with recommendations and options for further consideration and evaluation. So the second phase of the transformation work is very much now underway, led by the Agency of Human Services. This phase is taking a deeper dive into the feasibility and impact of, and the interaction, between the different options. So as such, we recommended in the policy, after consulting and collaborating with our colleagues at AHS, that we create a new resource that is updated as the transformation work is further developed and implemented. This resource would be a living document and would reflect the transformation actions that hospitals and AHS explored together, and would live on the Agency of Human Services Healthcare Transformation webpage. So that's just a little extra information there. Hopefully that helps folks think about where we landed. And moving right along, we have service reductions or eliminations being proposed to comply with an approved budget. This is really getting at actions taken to be compliant with a budget order issued by the Green Mountain Care Board. And then we have the statewide healthcare delivery strategic plan. This is Vermont's integrated strategic plan for an accessible and coordinated system of care, as outlined in Act 68 of 2025. Also, just want to note that this is not planned to be available until 2028. And then the community health needs assessment, which is the hospital's most recent assessment of local health needs. And it's just worth noting that these CHNAs, really vary in format and depth by the hospital. And they're also required every 3 years, which again, can present some limitations in their use in this case. So now we get into the notice requirements. You'll see here on the left, all notice documents will be posted to the Green Mountain Care Board's website. It requires that 45-day advance notice sent to all the parties on the screen. And the contact information for each of these entities is listed in the draft policy. And then in the blue box, we have the required components of the notice. And so that includes the description, the rationale, the alignment with plans, financial analysis, transition plan, and the timeline. And I'll just add a little bit more detail here. So the description is an identification of the services affected and the nature and magnitude of the reduction or elimination. So this covers, what specifically is being eliminated or reduced and by how much, and the type of elimination or reduction. The rationale is a justification and rationale for the proposed reduction or elimination. Then we get into the alignment with the plans. This is an explanation of how the proposed reduction or elimination is aligned with the state's healthcare transformation goals as outlined in Act 68. And those goals are listed in the draft policy. How it's consistent with the statewide healthcare delivery strategic plan once it's available, and or the most recent community health needs assessment, which needs to be submitted with the notice, and how it's compatible with the hospital's mission and vision. The financial analysis includes impacts of the change on gross and net patient revenue by payer, expenses, margin, and staffing, including underlying assumptions about volume, reimbursements, and the projected impact on both operating and capital expenses. The transition plan should describe how patients, staff, and other stakeholders will be notified and supported through the transition. This should include an identified best alternative site of care, describing the quality and accessibility of that site, including some supporting evidence such as, quality scores, wait times, or provider productivity. Patient, staff, and stakeholder notification plan, the coordination plan to facilitate the transfer or redirection of patients and their records to the alternative site. And then also include any preliminary agreement obtained by the alternate site and preservations for preserving network adequacy for Medicaid. We also have a timeline, which hospitals can provide the intended effective dates and milestones to the board and other groups. So the policy also states that the Green Mountain Care Board will check the notice for completeness and accuracy and may hold a preliminary hearing to decide if it will issue an order preventing the service reduction until after a public hearing and final decision. So the board would determine if any other information or a full submission is needed to make a determination. And if the board does not issue a written response within 30 days of receipt of the notice, the hospital may proceed with the proposed reduction or elimination. So that covers the notice information. And then we move into the full submission section. And this is a submission that would be at the request of the board. It is not required unless it's requested. So this is an opportunity for the board to dive a little deeper into the proposed reduction or elimination. In this section, we are asking hospitals to submit an impact analysis, list the alternatives that were considered, provide an updated financial analysis, and then any other additional information that the board deems necessary. And so again, a little more detail, which you can find in the draft policy, the impact analysis. We ask the hospitals to speak to impacts in a number of areas. This includes legal, licensure, or regulatory status, community access to the service. Think about, drive times, transportation options, wait times. And then provide 3 years of historical data on utilization and a 3-year forecast. We ask folks to speak to the quality of care, the connection to other related services that may be dependent on this service, the total cost of care reductions, population health outcomes, equitable access to the service, or cross-subsidization of the service line, or changes in other service areas. So let's see the next slide. Go. The GMCB may open a public comment period, which would be a minimum of a week, maybe longer, and hold a public hearing. So the board may consider whether or not to modify the hospital's budget or take actions as it deems appropriate to preserve access to necessary services. And hospitals are expected to inform their communities directly. So the next few sections of the policy outline the board's coordination with the Agency of Human Services, the Office of the Healthcare Advocate, and provides a non-exhaustive list of additional sources of information that may be reviewed to aid the board in its evaluation. So then we have just a flow chart to help visualize the process. Moving through here, right in the first box, the hospital submits their notice. GMCB reviews that notice, may hold a preliminary hearing to decide if it would issue an order preventing the service reduction until after the public hearing and final decision. And then the board determines whether, no action is taken, or the board may request a full submission or additional information or input. And in that full review, right, the board may issue a public notification and hold a public comment period. They would deliberate and make a decision and issue an order. So this slide shows the evaluation criteria. The board will be looking at each of these areas in their evaluation. So we have consistency with the statewide plan, which is not available yet. The CHNA alignment, right? The extent to which the proposed change would exacerbate or an acute or priority community need. Impact on access. Would patients face barriers to accessing the service? And we would look again what was requested in the notice and full submission around wait times or travel times and the availability of needed subspecialties. The quality of the transition plan. Impact on population health and quality of care. Affordability and cost impact. And hospital financial sustainability, right? The extent to which the change is necessary to preserve the viability of the institution, and the extent to which alternatives have been explored to maintain viability without harming access. Need to look at the system-wide impact, right? The potential of the change to have statewide as well as local implications, especially as we think about sort of patient migration and additional strain on other facilities that also have capacity constraints. And then regulatory compliance. So decision outcomes and enforcement. So as stated a number of times, right, the statute states that the board may modify the hospital's budget or take such additional actions as the board deems appropriate to preserve access to necessary services. So these decisions will be made public and will be posted to the Green Mountain Care Board's website. And then hospitals must comply with any imposed conditions, and GMCB may enforce compliance through its budget oversight authority. So the last section here in the statute states that the Green Mountain Care Board will, in collaboration with the Department of Financial Regulation, monitor the implementation of any authorized decrease in hospital services to determine its benefits to Vermonters or to Vermont's healthcare system, or both. So the Green Mountain Care Board will require follow-up reporting as specified in the order, and that may include, but is not limited to, looking at patient volumes or access metrics, quality outcomes, the financial impact, and patient, clinician, and community feedback. And the board may revisit decisions if unplanned negative consequences arise. So then that's sort of the end of the sections in the policy. Now I just want to walk through just a couple of important considerations here. So as stated before, this policy and process really cannot and should not be the only way that we are monitoring access to services. We need to build additional tools that help us more fully understand the evolving service landscape. So for example, the transformation work at large really needs to be considering service reductions and eliminations that fall outside the scope of this policy, gaps in access, because of staffing or recruitment challenges, incremental reductions in a service over time that don't trigger this notification process, or other factors. Right. And we also need to better understand and be able to forecast access to care in Vermont so that it can be stabilized and our system can become more resilient against sudden closures and abrupt or disjointed changes in service offerings. We need timely reporting, and it may be beneficial to have mechanisms in place to monitor vulnerable services, right? Those that are at risk. So we likely will need to refine the policy over time, given the very complex healthcare landscape and the numerous scenarios that arise impacting a hospital's service portfolio. So in developing this process, we're really trying to think across the regulatory work streams and maximize those opportunities to support hospitals in being planful and transparent. And we also certainly may need to revise the policy as the Agency of Human Services components and outputs from the transformation work, become more clear. And we will also look at this policy again once that strategic statewide plan is available in 2028. So in closing, this is still a draft document. As I mentioned before, we've really come to appreciate the complexity of the policy and want to acknowledge that we plan to learn from the implementation, and evolve over time. So I'll pull these slides down here, and we look forward to, starting the discussion today and then reviewing any public comments that we receive over the week, and coming back before the board maybe next Monday or maybe later, depending on the feedback that we receive, and then presenting a final version of the interim policy for a board vote. So with that, I will turn it back to you, Member Holmes. Thank you so much.
Great. Thank you, Hillary. Fantastic work here, a great draft document, lots for us to consider, and a really thoughtful presentation. So thank you for that. I'm going to turn it to the board for questions. I'll open it up. Member Merman, you're here. Do you want to go first?
Here, thank you. Yeah, Hillary, I agree. I think I really appreciate how you have laid out the various considerations and developed those areas. I think there's some additional tweaking and development I'm sure that's going to occur, but I found that through this process very helpful and rigorous. I guess a few questions that I want to talk about, and I think these aren't going to have clear answers, I guess, which is when we talk about the service reduction policy, I think I would like to do some more thinking before committing, and maybe some discussion with staff about the thresholds of entering the policy. When we say 50% reduction of a service, if we need to think about that, say if there's primary care services, if that's 50% reduction in a locality versus 50% reduction of the overall service. If we think about, I'm just going to sort of throw out some cases that have come to the board. If we think about dialysis services, you think about over 50% reduction in a locality versus 50% reduction in the overall dialysis services. I think the intent of this is for us to consider those things that occurred, that could have occurred previously. So that's just something I was thinking about through that as you were presenting today that I have not, when I read it, have not thought about it. Again, sorry, I should have questions as opposed to more comments on this. I did want to just sort of flag on education. I think the intent there is patient education as opposed to reduction in saying nurse education, physician education, medical student education. So I think just like a little quick note on that, if that's the intention. And I really appreciate the sort of the notice criteria differentiating from the full submission criteria. And I think I wanted to sort of hear what you thought about what you meant by equitable access in the context of the impact analysis, and if you're thinking about how we would expand on what that means a little bit.
Yeah, I think thinking about equitable access was, if the service is being moved, how do we ensure that folks with Medicaid are still accepted, right? And are there disproportionate transportation barriers when we think about, a next alternative site? So I think, again, trying to apply that lens of community access, looking at the population that's served by the service and ensuring that, we have maximized the pathways and opportunities for everyone to access that service, at a different site.
Yeah, great, thanks. That's where I was as well. So I appreciate that we're on the same place. And then the last thing I wanted to discuss really, and I appreciate your emphasis on the monitoring, especially monitoring access to services. And I think we need to spend some time thinking about what that really means. If in a world we switch to global budgets, you would hope that when you switch to global budgets, you can have more efficient delivery of healthcare, which may look different. And so there may be less of something and more of something else. And how do we think about that from the end user, from the patient or the general population? And so I think there's some complexity about how to think about that. I don't think this is I don't think anyone's defined a really efficient way to do that, at least in the United States. So I think we may have to look outside for models, but I really think I think there's a huge importance, and I think this has come across for years now in multiple different contexts, is the importance of monitoring the system and access to the system and the efficiency of the system and for who we are monitoring that for. So that's my only comments for this morning.
Thank you. Yeah, I absolutely really have come to appreciate, as you're sharing, the need and probably the developing need as we implement this policy for additional monitoring tools and, sort of looking at how we continue to survey the system. So that's hopefully going to be an area that we really dig into, as we stand this up and think about our work moving forward.
Thanks.
Great, thank you. Member Teachout, any questions or comments for Hillary?
I do. Thank you, Hillary. Maybe more questions that you probably can't answer right now. So I fully appreciate that these aren't easy. So when I think about the transition plan, one of the things that I'm not sure of is who would be responsible for ensuring a smooth transition. Say you're eliminating a service, you're no longer providing it. Is the hospital that's eliminating the service responsible for the transition plan? Is it a collaboration with the state? Is it a collaboration with other providers? Just not quite sure. You can have a great plan, but if no one's in charge of it, it's not going to work very well. My next question was about the network adequacy for Medicaid, and you brought it up, I think, in the context of how to evaluate And I didn't know if network adequacy for Medicaid was significantly different than that for a private commercial health insurer or some other. Do you know that, or is that something I should look up?
Yeah, I would have to follow up to get a little bit more information there, for maybe the level of detail that you're wanting.
Okay. I just know that network adequacy standards have been changing a little bit in recent years, and so I'm just curious to dig a little deeper in that, and
Okay.
not something we have to do here. Just to jump to another topic, the financial analysis. I think doing the analysis for hospital sustainability probably isn't as difficult as doing the analysis for the financial impact to the system or to payers. And so I'm more concerned about the second part. How is it going to impact costs across the system? So that's the one I'm more interested in, and I'm not sure how we get at that, because I think it'll be harder for an individual hospital to do that. And so that jumps into my next concern. I'm just going to raise it for the full submission. I appreciate how comprehensive it is, but I also appreciate that it could easily require a consultant or outside resources to help do that. And I'm a little bit worried about kind of just additional costs and burdens in the system, and that we need to balance the cost of regulation with the cost to comply. And that's my only concern. And I know it's really easy to ask for a million things, and all the data and all the information. But I just want to balance out, is everything we're asking for necessary to make a good decision? And it may be. And my last, again, more comment than question, Hillary, is I know that I think the statute says we have to monitor with the Department of Financial Regulation, and I'm still a little unclear on how we're working with AHS, who's sort of tasked with overseeing the reform transition, and then what DFR's role is in that, because they don't typically, at least in my experience, play a big role in hospital services. So I guess maybe understanding that a little bit more, like the roles of those entities.
Yeah, I think it's a great flag, and probably one of those areas that we're going to need to learn as we do, and then revisit the policy. I think there are many folks that are engaged in transformation efforts and have, different pieces of the puzzle and different data and different ways of interacting with the delivery system. So it is written into the statute, as you stated, to work with DFR around the monitoring. And I think as we, stand this up and try to figure out what kind of ongoing reporting is helpful in looking at the impacts of these changes, we can further sort of clarify and define those roles, and, who can sort of do what, and, to aid the board in reviewing, and then also aid the board in understanding and monitoring the impacts. So I think we have to live and learn a little bit in that space.
Great. Thank you. That's all I had, just my thoughts. And I appreciate yours as well.
Thank you.
Great. Thanks. Member Walsh.
Thank you, Member Holmes. Thank you, Hillary and team, for excellent work. This is something we're all learning a lot about as we think about this. And the situation we found ourselves in last spring was sudden closures of needed services and threats of further closures really points out the need for system-wide oversight. So I understand why we're here. At the same time, I think it's a very difficult type of regulation. We're not CEOs or CFOs. And so what I'm wanting more information about, or help thinking more about, are situations where the pieces of the puzzle don't all line up. For instance, a delivery system's finances could be in dire straits, and their transition plan may be poor. So we may not like the transition plan and we may want to deny the reverse CON. But their finances are in jeopardy. So how would we navigate something like that? I'm not sure yet. Somebody needs to help with it, but I'm not sure how that gets done. I read through the material that you provided about Connecticut that has an existing reverse CON. I noticed they have financial penalties for non-compliance. I wonder how that would work in our situation if a hospital is filing for a reverse CON because of budgetary reasons. It's similar to what Member Teachout was saying a moment ago. The cost of closure is something we may have to consider. So I guess my question is, have you or are people considering financial penalties?
So, I'll just share my perspective, right, which is I didn't think that we wanted to go there yet. I think that for many of the reasons that you just shared, right, if there are significant financial concerns at an organization and they are proposing a reduction or elimination as sort of a last resort, right, and then we want that service to stay open. And there's tension there, right? There's maybe the inability to do that. I'm not sure that monetary penalties are really going to help us achieve the desired outcome. I think that's absolutely an area for the board to dig into and talk about in terms of what we, how we want to enforce compliance. And I think it's part of a broader conversation with partners across the state to say, what are the other supports and resources available to help us move through these situations, right? Yeah. I don't know all of those resources and supports. And so I think, we want to build the policy out in a way that allows the board to receive, additional information that can help you think about the right decision to make. And so, yes, I think we talked with the folks in Connecticut and, and I think they also were really aware of the limitations of that tool in enforcement.
Yeah, I appreciate that. I appreciate all the work you're doing. I understand what got us here. I like what you were just saying about working with the rest of the system, hospitals, our government partners, to try to make this a rarely used safeguard rather than a routine regulatory process. That's it. Thank you. Great work.
Thank you.
Yeah. So I agree with so many of the thoughtful comments of my fellow board members here. I think this is a great first pass, at a new regulatory policy. I think we do have to really consider the delicate balance between regulatory oversight and administrative burden. I think we're going to learn as we go, as you said, so carefully and thoughtfully. I think we're going to learn as AHS develops this statewide, strategic plan. I think we're going to see how this policy fits in as care transformation unfolds. But I really appreciate the thought that has gone into this policy as an interim policy. A couple of quick questions. I just want to clarify that this would apply to all 14 hospitals and the Brattleboro retreat. Is that right?
That is correct.
Okay. And I also, in terms of the definition of the reduction being 50% or more, and I think you raised this about incremental changes to service lines. I think we need to think about, is 50% the right number? Maybe it is. You know, if a hospital reduces a service line 25% in 1 year and 25% in the second year, it wouldn't, you know, fall under this policy. So are there ways to allow inquiry into future planned reductions in some meaningful ways? So I just want to think about that some more. And I guess the other thing I would add, there was a definition of vendor, or do we need a definition of vendor in the change of ownership and outsourcing type notification? And I wondered whether, say, for example, Dartmouth Hitchcock assumes the delivery of radiology services at a particular hospital. It's been outsourced as that service. Would that be captured in the term vendor? So I just want to, you know, open that up for further definition, perhaps. I don't know if you have thoughts on that.
Yeah, I mean, a couple responses here. I mean, I think you're absolutely right. And what I said in my remarks too was, you know, we need to stand up some additional ways of monitoring changes, because I think that you know, the transformation work really, you know, we need to think holistically across the system, you know, and make sure that we're aware of how things are changing. And so it's a great question in terms of, do we need additional clarity around sort of the outsourcing or a vendor providing a service for a hospital? And I think I'd love some board input here, right? Like, to me, I'm like, you know, do we want that? To me, significantly does change, you know, the service, or at least the oversight of the service. And so, you know, I guess it's a question back to the board in terms of, is that something that we would want to be included in this policy, especially, you know, in the absence of some of these other tools that we want to build out and develop over time. So I'm really open to, you know, where we need to tighten some of these definitions, and also aware of, you know, not being able to predict all of the situations that we might find ourselves in. And I know we're going to have to work with hospitals to navigate, like, you know, is this subject to the policy? Is it not? And so I really am striving to have as much clarity as we feel like we can provide right now, but it may be that defining vendor is helpful, or at least specifying whether or not other hospitals are included in that.
Yeah, thank you. And you know, I agree with you. This is going to be a work in progress, and I think, you know, I think I'm really looking forward to the public comment on this, and to see if others have suggestions. One slight edit I think I might make, related to Member Teachout's point. I think I might just leave it preserving network adequacy in that section, without, you know, making it only for Medicaid, right?
Yeah.
So this section under transition plan, you know, just Part E, provisions for preserving network adequacy, and leave it there as a suggestion. At this point, are there any other board questions or comments? I think I'll turn it over to the HCA for comment or thoughts.
Yep. Hi, Member Holmes. Thank you. Charles Becker for the HCA. We just want to express our appreciation to Hillary and her team for their excellent work transforming the legislative language into a workable policy. Also appreciation for giving us a preview of the draft last week and an opportunity to provide input. There's a lot that went into this policy, and there's a lot to think about. We'll review the full draft as a team and submit any comment we have in writing on the draft. So thank you.
Great. Thank you, Mr. Becker. At this point, I would welcome any public comments. If you want to, you know, make a public comment, please use the raise your hand function. I'm seeing one. Ms. Green from VAS. Hello, how are you?
Good morning. I'm Devin Green from the Vermont Association of Hospitals and Health Systems. And Hillary, I also wanted to express our thank you for giving us an opportunity to have a bit of a preview of the policy as you wrote it. And I'm having a little trouble finding it online. So if you can direct me to where it is posted, I think that would be helpful. But I did want to stress that this concept and this policy has a lot of tension between affordability and access. And what I'm hearing today, I think further stresses that a bit when, or stretches that a bit. When the legislation was passed, when Act 68 was passed, there was the concept of a 45-day notice period, which would give the opportunity for impacted parties to understand what's happening and also give the Green Mountain Care Board an opportunity to evaluate the change and step in if necessary. What I didn't see in the statute was the ability for the Green Mountain Care Board to actually stop the change from going into place while it's being evaluated. I think the legislation anticipated a very quick process, and this sounds like it could be a very long process, typical to what we might see with a certificate of need. And I'd just like to remind the board that in that time, what the hospital is trying to do is be in compliance with the budget. So it feels like we're in between a rock and a hard place with trying to be in compliance with the budget, but then also trying to be in compliance with this. And we are under the gun for time in trying to actually effectuate the changes so that we can create affordability for hospitals. And so we would advocate for this to be as streamlined a process as possible. The legislation has the board evaluating this against the CHNAs until the statewide plan is developed. And so, again, we would advocate for streamlined, quick, but effective process in this space. The other thing I'd just like to point out is I need to look at the services piece and the definition and grapple with that a little bit more. I'm not sure if this was addressed in there, but one thing we were concerned about was the staffing piece. There are times when, and maybe this gets at it with the intentional part, but there are times when hospitals have a big flu outbreak amongst their staff and they can't control that, and beds are unavailable and services are reduced by more than 50%. And so we want to make sure that we get at those situations outside of the hospital's control there. And then the final piece I would just add is, you know, hospitals have been tasked with creating more affordable care. They've been asked time and time again to do it quickly. And one thing that has been pointed to in doing that is the Oliver Wyman report. And some hospitals are looking to follow that. To hear that is following those recommendations is not going to be exempt will again sort of slow down the process a bit more. And so we would ask that the Oliver Wyman recommendations be included as exemptions until that list is made that Hillary referred to in terms of exemptions. Thank you.
Great. Thank you for those comments. And Ms. Green, if you want to follow up in written format, that would be super helpful. Yeah, thank you.
Thanks.
Any other public comments? Please use the raise your hand function. Okay, I'm not seeing any. Again, though, we would welcome any other public comment. People can submit, to the board. We read everything. This may be up for vote, as Ms. Watson said, next September 15th. But if, there's an opportunity and there's a lot of public feedback on this, that may be postponed. So we do welcome all of that public feedback. Is there any old business to come before the board? Is there any new business to come before the board? All right, well, then I think with that, I want to thank you, Ms. Watson, for all of your hard work on this. And I know there was a staff behind you helping you as well. I look forward to the public comment on this and further discussion about this. It's a pretty important new policy that the board is engaging in. And with that, I guess I will entertain any motion to adjourn.
So moved.
Is there a
I'll
second?
second. I'll second.
Great. Thank you. All those in favor, please say aye.
Aye.
Aye, aye. All right, we are adjourned. Thank you all. Hope you all have a good rest of your Monday, and thanks for all the time and engagement in this important work.